Yes, I am stick to P. Okay. This patient has this patient had a fall with this patient had a fall with shock. This patient had a fall with shock that rapidly progressed to cardiac arrest. Beside clues can help to deduce shock etiology. This patient's hypotension and initial tachycardia were accompanied by two signs of acute heart dysfunction, JVD, and new right bundle branch block. Given his postoperative status, thrombotic risk factor, sudden symptom onset, and tachypnea obstructive shock due to pulmonary embolism should be considered. With a massive PE, systolic blood pressure less than 90 millimeter of mercury, the right ventricle cannot eject against acutely increased afterload. As a result, there is sudden drop in the cardiac output. Therefore, a massive pulmonary embolism often presents with a fall or syncope as in this patient. In contrast to smaller or segmental pulmonary embolism, symptoms of focal pleural irritation or pulmonary ischemia, chest pain are less common. If right ventricular obstruction is untreated, thrombolytics hemodynamics deteriorate. Global vein perfusion can produce neurogenic signs and confusion, unintelligible speech, dilated pupils. With a low output shock state developing thready pulse, peripheral vasoconstriction, inability to capture pulse oximetry, decreased pulse pressure, transition to bradycardia signifies depletion of myocardial injury, depletion of myocardial energy stores, and commonly precedes cardiac arrest. Okay, is it P? There is. Okay, maybe. Okay. Pathophysiology of the massive pulmonary embolism. Massive pulmonary embolism, right ventricular obstruction, and increase right ventricular pressure. There may be right ventricular hypokinesis, decreased right ventricular output, and decreased left ventricular output and cardiac output. Decreased left ventricular output and cardiac output. Decreased right ventricular oxygen supply, which will decrease the right ventricular ischemia infarction, and there is right ventricular failure. And right ventricular outflow obstruction and increased right ventricular pressure will increase right ventricular dilatation, increase right ventricular wall tension, increase right ventricular oxygen demand. There is further ischemia infarction and right ventricular failure and shock. Okay, these patients underlying malignancy, prothrombotic state, an acute presentation of dyspnea, chest pain, tachycardia, hypoxia, and clear lungs are highly suggestive of pulmonary embolism. Patient with massive pulmonary embolism can present with syncope and hemodynamic collapse. Examination can show an accentuated loud pulmonary component of the second heart sound, and elevated central venous pressure, high jugular venous pressure (JVP), acute massive PE, acute massive PE in abrupt increases in pulmonary vascular resistance and subsequently right ventricular pressures. Elevated right ventricular pressure causes an increased right ventricular wall tension, cardiac muscle stretching, and right ventricular dilatation. These increases right ventricular myocardial oxygen demand and decreases coronary artery perfusion, which causes supply or demand mismatch and right ventricular ischemia. Consequent right ventricular dysfunction can lead to an inability to pump blood through the pulmonary circulation, decreased venous return to the left atrium, decreased cardiac output, and potential hemodynamic collapse. Besides, echocardiogram can show bowing of the septum into the left ventricle due to right ventricular pressure exceeding left ventricular diastolic pressure and right ventricular free wall hypokinesis with sparing of the apex. The presence of right ventricular dysfunction along with elevated BNP and troponin level is associated with increased mortality risk. It may be difficult to differentiate PE from right ventricular myocardial wall infarction, which can cause right ventricular dysfunction. However, right ventricular myocardial wall infarction is less likely to cause dyspnea or syncope and more likely to cause bradycardia or arrhythmia. Okay, yes. fever. No, what is it? Is it hypoxic pulmonary? Is interpulmonary shunting? What is this? Okay, look at the question. Look at the picture. Pneumonia down. So lying down on that side where there is pneumonia, it will increase the perfusion on the poorly ventilated area, so increase VQ mismatch, and there is worsening hypoxemia. If sleeping opposite side, like if right-sided pneumonia, if right lateral, if the patient, uh, what can I say? If the patient lies on left lateral position, that means pneumonia up and decrease perfusion of poorly ventilated region and decrease vacuum mismatch and improve hypoxemia. So these patients fever, pleuritic chest pain, these patients fever, pleuritic chest pain, hypoxemia and dullness to percussion with bronchial breath sound in the left lung, in the left lung fluid are consistent with alveolar consolidation due to pneumonia. Pneumonia causes hypoxemia due to ventilation perfusion mismatch from localized interpulmonary shunting. Pneumonic consolidation are not ventilated V equal to 0 but continue to receive blood flow Q. When this patient with left-sided pneumonia is in the left decubitus position, pneumonia side down, gravity, pneumonia side down, gravity increases the fraction of the blood going gravity increases the fraction of the blood going to the consolidated lung. This leads to more profound VQ mismatch. Ventilation in the consolidated lobe remain very low but blood flow increases. So ventilation in the consolidated lobe uh, remains very low but blood flow increases, further lowering the overall VQ ratio and worsening hypoxemia. The opposite occurs when the patient is in the right decubitus position. Right decubitus position, like pneumonia side up, because blood is redistributed away from the consolidation, leading to more favorable VQ mismatch and improved hypoxemia. For yes, for this reason, patients with unilateral lung air-space disease pneumonia often prefer to lie on the contralateral trepon- trepopnea, that is trepopnea, and hypoxic pulmonary vasoconstriction is the physiologic mechanism by which the lungs reduce perfusion to a poorly ventilated alveoli consolidated by pneumonia to preserve VQ mismatching. The degree of the hypoxic pulmonary vasoconstriction is determined by alveolar oxygen tension and is not affected by changes in position. Okay, B and C. Decreased minute ventilation. Decreased minute ventilation occurs when either the respiratory rate or the tidal volume is decreased. On these patients, pleuritic chest pain may have positional component leading to some effort-dependent hypoventilation, shallow breathing, resulting in decreased tidal volume, but his respiratory rate is not achieved. Sorry, but his respiratory rate is elevated and a significant decrease in minute ventilation is unlikely. Okay, yes. Sorry, peribronchial coughing. Yes, it's a keyword for disease. Bilateral. Wait. Uh, um, peribronchial coughing. Is it trans transient tachypnea of the newborn? No, 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 no. No, no, it is not the answer. Yes, I know that. And the diffuse interstitial markings. Is it bronchiolitis? 18 months, less than 2 years. Para RSV, respiratory syncytial virus. Bronch, then yes. Is it bronchiolitis? No, no, no. We don't. In bronchiolitis, we don't. It's like normal disease. Like it will treat by its own. Coughing. Yes. Okay, and so this patient has bronchiolitis, peribronchial coughing. Okay, this patient has bronchiolitis and a lower respiratory tract infection in children age less than 2. Symptoms typically begin with upper respiratory symptom, cough, nasal congestion that progress to lower respiratory tract, wheezing, crackles. Infection usually peaks days 3 to 5, often with increased work of breathing, tachypnea, retraction, and hypoxia. Bronchiolitis is usually diagnosed clinically, however, X-ray chest may be warranted to exclude other causes. Pneumonia in patients with severe symptoms, hypoxia, apnea, and typical progression such as this child with worsening symptoms after the day 5 of illness. Common X-ray findings include increased interstitial marking and peribronchial coughing, bronchial wall haziness due to inflammation, hyperinflation, and atelectasis may be present, but focal consolidation is typically absent. Treatment for bronchiolitis is supportive, including suctioning the nares and maintaining adequate fluid intake. Patients who are well hydrated with adequate oxygenation, typically defined as more than 92% in bronchiolitis, only mild intermittent increased work of breathing, as in this case, can be managed as outpatient with clear can be managed as outpatient with close follow-up. Okay, glucocorticoid and bronchodilator albuterol can be managed for patients with bronchiolitis, a history of recurrent viral triggering wheezing. A trial of albuterol alone may also be considered for a first-time episode of bronchiolitis and severe symptoms, hypoxia, providing transient symptom relief in some. However, this patient has no prior wheezing history and has normal oxygenation with only mild intermittent increased work of breathing. Okay, is it anaphylaxis? Because there is arterial rash after taking an ibuprofen. Yes. Okay. This patient with acute onset respiratory distress, hemodynamic instability, and arterial rash likely has anaphylaxis. The most common diagnostic criteria for anaphylaxis include an acute illness involving skin or mucosa, either respiratory or cardiovascular compromise, hypertension, or signs of end organ hypoperfusion. Other common manifestations include GI, neurologic, ocular symptoms. If the diagnosis is unclear, serum tryptase or plasma histamine may be helpful. The development of pulmonary symptom after breakfast suggests possible food allergy. Risk factor for anaphylaxis include immune disorders such as asthma and muscle disorder. Patients with underlying pulmonary or cardiovascular comorbidities are at increased risk of poor outcomes. Medications such as NSAIDs or beta adrenergic blocker can exacerbate anaphylaxis by resulting in non-immunologic muscle activation or unopposed alpha adrenergic effects, respectively. Treatment involves supportive care, including ARA management and medications such as intramuscular epinephrine, the preferred treatment. Okay. ENF. Okay. Anaphylaxis may be confused with asthma exacerbation if skin involvement is minimal or missed by the clinician. Cardiac tamponade can also present with dyspnea and hemodynamic instability. Neither would explain the patient's diffuse arterial cough or arterial rash. This patient and option E and F. This patient history of recent trauma places him at risk for pulmonary contusion and tension pneumothorax. Pulmonary contusion typically presents with tachypnea, tachycardia, hypoxia within 24 hours of blunt trauma and result in result in acute respiratory distress syndrome. Tension pneumothorax is characterized by rapid onset severe dyspnea, tachypnea, tachycardia, hypertension, and neck vein distension. Pulmonary contusion, tension pneumothorax, ARDS are not classically associated with skin involvement. Fluid within the fissure. This is the classic X-ray finding of transient tachypnea of the newborn, isn't it? And less than uh, like more than 28 days of oxygen. What is the diagnosis? Dysplasia, yes. Bronchopulmonary. And the transient tachypnea of the newborn is like delayed reabsorption of the fetal alveolar fluid, like in happens in preterm or term infants. Okay, usually the prematurity, the C-section. Okay, next. PaO2 is more than 100. Normally it's 80 to 100. It is more than 100. Like hyperoxygenation. It is ARDS, isn't it? Because after 3 days he developed respiratory distress, and he has like, what can I say, risk factor like ARDS. I remember it this way. For diagnosing ARDS, we have to look at the past. For past is pancreatitis, aspiration, sepsis, and trauma. Yes, we will touch the respiratory rate, isn't it? If we decrease the respiratory rate, uh, okay, you give your answer. Yes, we can increase the like hyperventilation will, yes. So so we can increase the respiratory rate. What is your answer? We are looking at the wrong areas. My first observation was correct. Like patient is on hyperoxia. Now think, it's not normal. Like if oxygen is above 100, then you need to do something. Like uh, fraction of inspired oxygen should be decreased. Okay. So this patient, this patient has acute pancreatitis, which is now complicated by ARDS. In patient with ARDS, mechanical ventilation improve oxygenation by increasing FiO2 and PEEP to prevent alveolar collapse. The goal is to maintain PaO2 60 to 90 millimeter of mercury, corresponding to an oxygen saturation 92 to 96%. Immediately following intubation, high FiO2 is usually provided and can subsequently be adjusted based on the results on the first ABG analysis. PaO2 is influenced by PaO2 is influenced by FiO2 and PEEP. In this case, the initial ABG values indicates excessive oxygenation hyperoxia. Prolonged exposure to high FiO2 can induce oxygen toxicity via formation of post pro-inflammatory reactive oxygen species, leading to cellular toxicity and propagation of lung injury. It also worsens atelectasis by displacing nitrogen gas from the alveoli. Nitrogen is poorly absorbed in the bloodstream, and helps keep alveoli open. Although this is no strict cutoff value, FiO2 less than 60% are FiO2 less than 60% are generally considered safe. Therefore, these patients' FiO2 should be lowered. A compensated increase in PEEP is required to maintain adequate oxygenation. Okay, okay, okay. Tomorrow,